Alright guys, so today I'm Road to 250. I'm going to talk about CSF flow and hydrocephalus types. So to start off with, CSF is made and CSF is like essentially the flow of our ventricular system. It's made by the choroid plexus, which line, and the choroid plexus cells is what makes CSF, and the choroid plexus cells line also the lateral ventricles. So that would be here where my hair was. And it's then reabsorbed by the arachnoid granulations and into the venous sinus system. So venous sinus system is important later in the presentation. So then flow from the lateral ventricles up here goes to the third ventricle here at the center location via the foramen here, which is labeled interventricular foramen, but it is called the foramen of Monroe, or also known as the foramen of Monroe. And then CSF flow from the third ventricle to the fourth ventricle here also travels through a foramen, and that one is known as the aqueduct, or cerebral aqueduct. And then from the flow continues, and the fourth ventricle has three outflow tracts. One is the foramen of Luschka, which is this one sticking out here. It's also the lateral outflow tract. So Luschka, you can L for Luschka, L for lateral. And then there is the medial outflow tract, and that one is the foramen Magendie. So Magendie M for medial. So again, just another view of it. Lateral ventricles travel to the third ventricle via the right and left interventricular foramen of Monroe. Again here, and then third to fourth via the cerebral aqueduct of Sylvius. And then the fourth ventricle has the foramen of Luschka, the lateral, and then foramen of Magendie, the medial. And then in addition, the choroid plexus are a derivative of ependymal cells, so that is important. And then essentially travels to the subarachnoid space via the foramen of Luschka and Magendie, and has and drains into the dural venous. Any questions so far? Mm-hmm. Okay. This slide is a little misplaced. Sorry. So hydrocephalus. So hydrocephalus is essentially this fluid accumulation in our brain, and it's specifically an increase in CSF and therefore intracranial pressure. And as a result of increased CSF volume, we also get ventricular dilation. So hydrocephalus types are broken down into communicating, non-communicating. In the communicating, there is essentially an impaired resorption at the arachnoid granulations, or there is excess CSF production. And so it's communicating because there's no obstruction within the ventricular system itself. So everything is communicating between the foramens, for example. And because there is decreased absorption, there's going to be increased intracranial pressure, and that can manifest as papilledema or herniation in the brain. A type of question you could see this with is going to be associated with a recent meningitis patient who's still recovering, and because they are recovering, they have scarring of the arachnoid granulations that's impairing their ability to reabsorb CSF, and so that could be why there's excess CSF. And so, again, increased ICP and papilledema. And then it's always good to kind of have a general idea of the MRI. It feels like questions will tend to show it. And if you can just kind of pick it out, it makes things a little easier on your end. So ventricular dilations is what you're definitely looking for here. Then the normal pressure hydrocephalus. So the normal pressure hydrocephalus falls under the communicating. So again, there's no obstruction. Everything is communicating within. It's commonly seen in elderly patients. So and the ventricles are abnormally dilated. But CSF pressure is not elevated. So no increase in ICP in normal pressure hydrocephalus. The cause is going to be, for the most part, impaired CSF reabsorption, again, at the arachnoid granulations. And these patients' symptoms are presented in a triad, which is urinary incontinence, gait, ataxia, and dementia, also known as wet, wacky, and wobbly. And most questions are just super obvious when it comes to that. You can pick it out quite quickly. And if, again, you're familiar with MRI, that'll just make it that much easier. And this also occurs as a result of reversible cause of dementia. So to kind of, and then as first aid said, affects the elderly, it's idiopathic. CSF pressures only elevate episodically. I've read from DIT is where I got its CSF pressures not elevated. So I guess episodically. So it could be normal to not elevated. And does not cause an increase in subarachnoid space volume. So I guess that's important. And then you will see expansion of ventricles, as you see, and distortion of fibers of the corona radiata. And then you get the triad, wet, wacky, wobbly, and symptoms potentially reversible with CSF shunt replacement. So that's our normal pressure hydrocephalus. Moving on to the non-communicating. So the non-communicating types indicate that there is an obstruction of flow within the CSF system. There will be enlarged ventricles, and it could be secondary to a supercella cyst. The most common location of obstruction is the aqueduct of Cilius, and the symptoms that manifest in these patients would be headache, nausea, vomiting, cognitive decline, altered mental status, papilledema, cranial nerve 3 palsy, and cranial nerve 6 palsy. So I've seen both in different notes. So if anybody has anything that they'd want to add on to that matter. But it would make sense why our nerves are going to get compressed and cause a palsy overall. So as first aid says, caused by structural blockage, and most commonly at the aqueduct of Cilius, and a colloid cyst could be blocking the foramen of Monroe, and it could also be a tumor as indicated by the red arrow in this MRI picture. Any questions? Everyone good?
Yep.
All right. The last of the hydrocephalus is going to be one that mimics hydrocephalus. This is called ex vacuo ventriculomegaly, or hydrocephalus ex vacuo. This occurs in areas of previous brain damage. So brain tissue is resorbed and replaced with CSF, but it's not symptomatic. But you will see very dilated ventricles and extensive cortical atrophy. This is important, commonly seen in patients with Alzheimer's, advanced HIV, PIC disease, Huntington disease, hence the previous areas of damage. And a patient could present as one with progressive cognitive decline with hydrocephalus on imaging. So that will kind of be your clue that they might have some history with any of these diseases. Intracranial pressure is normal, and you don't see the wet, wacky, and wobbly in these patients. It's just going to be more so with the dementia, but no wet and wacky, or wobbly, sorry. Yeah, And again, decreased brain tissue and neuronal atrophy. That's important when you're looking at the MRI. And again, I think I found that this one was also good to know with familiarity of what the MRI looks like. So that's my short little presentation here. I have a couple of questions for you guys if you don't have any for me. But if you do, or any comments, questions, please do ask away.
Well, let's see what you got.
Alrighty. So first question is, a mother brings her 3-week-old infant to the urgent care stating that he has been feeding poorly while acting extremely fussy over the last few days. His birth history is remarkable for an episode of Group B strep meningitis that resolved after a full course of high-dose IV ampicillin. His temp is 98.6, heart rate 130 per minute, blood pressure 85/55, respiratory 35 per minute, and O2 sat 100%. He is noted to have increased head circumference and bulging anterior fontanelle on exam. Which of the following mechanisms is most likely responsible for this patient's signs and symptoms? A. Accumulation of blood in the subarachnoid space. B. Decreased reabsorption of CSF fluid by the arachnoid villi. C. Increased production of CSF. D. Recurrence of incomplete treated meningitis. Or E. Ventricular obstruction.
I'll go with B. We've got the arachnoid villi scarring due to this kid probably had meningitis. Oh, yeah, it's meningitis.
The child definitely had a episode of meningitis that was treated. Divya, feeling the same?
I said B the same time he did, so I don't know if...
Oh, okay.
Yeah,
more masculine over yours. Yeah, totally right. There is the subarachnoid, so those granulations were scarred, and so that's impairing its absorption. And then like A would be more something like encephalopathy maybe, or like bleeding, like vitamin K, maybe more so vitamin K deficiency, so the baby bled out into the brain. Hemorrhage into the brain.
That's a good one.
I had a question on that once before. So yeah, vitamin K deficient, like maybe they did an at-home birth and the child didn't get the vitamin K shot. So that could be one. And we know that blood irritates the brain. So yeah. Okay, next one. A 78-year-old man comes to the physician for evaluation after falling 5 times in the span of 2 months. An X-ray skeletal survey reveals no fractures, but the patient admits to worsening urinary incontinence over the previous 4 months. His wife states that his memory and concentration have deteriorated recently. The patient's vital signs are normal, and his physical examination is notable for a wide-based gait with short steps. A mini mental state examination results in a score of 24 out of 30. His fundoscopy examination is normal, and his neurological examination is notable for slight bradykinesia without tremor. His lab results are as follows. And the question is, what is the most likely cause of the patient's recent decline? And it seems like his BUN's a little high there for sure, but everything else is just about normal.
He's wet, he's wacky, and he's wobbly.
Exactly. And so you guys are going with E?
Normal pressure.
Mm-hmm. Yeah. Yep, that's exactly right. So yeah, I've always found that these questions are pretty to the point. All right, last one. An 84-year-old man presents to his community health clinic saying that over the past year he's had difficulty walking and holding my urine. He also feels that he's become more forgetful. His father, who accompanies him, says his family and friends had assumed the memory and gait difficulties were just his age catching up with him. But the incontinence caused him enough concern that they decide to seek medical advice. Physical examination reveals no visual field changes or tremors, but the patient has an unsteady gait and shuffling feet. Non-contrast CT is shown, which I'll show you in a second. The primary defect in this patient's disorder occurs in the structure that drains into which of the following venous sinuses? And this is the MRI. A, cavernous sinus. B, confluence of sinuses. C, sphenoid sinus. D, straight sinus. E, superior sagittal sinus. F, transverse sinus. I know I didn't talk about sinuses, but I thought this could maybe just jog our memory since we're on the topic.
So we're talking normal pressure hydrocephalus together.
Right.
So these are the transverse sinuses that are dilated. So you're talking about where they would.
Right. The question is.
What?
Yeah.
Disorder occurs in a structure that drains into which of the following sinuses? So the transverse sinuses normally drain into the confluence of sinuses?
No, not quite. So it's the superior sagittal sinus. Because it's where the collection of venous blood where arachnoid granulations drain CSF from the subarachnoid space into the bloodstream.
Oh, okay.
And I do have the full explanation attached in this PowerPoint in the notes, which I'll look at real quickly here, actually. But yeah, so okay, obviously, yeah, it's clear that the patient has normal non-communicating head. I don't even know anymore. NPH.
Normal pressure.
Caused by inadequate.
This patient is caused by inadequate resorption of CSF by clogged arachnoid granulations, which drain into the superior sagittal sinus. And the superior sagittal sinus is a collection of venous blood where the arachnoid granulations drain CSF from the subarachnoid space into the bloodstream. So it occurs via that.
Okay. All right.
So, yeah.
Well, that makes sense. Thank you.
Alrighty. Well, that's what I got. I was going to do the management, but we kind of just recently talked about carbonic anhydride to decrease the intracranial pressure. So, didn't there. And then I guess the other choice of management would be the shunt, like I mentioned in the communicating hydrocephalus. So that's kind of your overall management that I know of. Unless, Pete, you have anything else to add on from step 2?
No, I haven't done anything neuro. I think you can use Manos also to decrease CSF pressure, if I'm not mistaken.
Okay. Yeah.
Cause an osmotic diuresis.
Yeah.
Just kind of dehydrate the patient.
Yeah.
But
yeah,
I know
definitely.
you're going to go with carbonic anhydrase first, for sure.
Okay. Yeah. Cool. Thanks, guys.
Short
for
and
hanging
sweet
tight.
presentation.